For 20 years, a terrifying FDA warning label basically convinced millions of women that taking hormone therapy would lead directly to dementia.
Yeah, it really did.
And today, we are going to look at why that black box label was finally and very quietly removed and, how the medical system got menopause so incredibly wrong for so long.
I mean, it is staggering when you look at the sheer volume of misinformation out there.
Right.
We have spent decades treating menopause with either unwarranted panic or just these dismissive shrugs, which leaves patients to navigate some incredibly complex physiological changes completely in the dark.
Which is exactly why we are pulling apart a really amazing treasure trove of clinical data today. Welcome to the deep dive. We are sourcing our material today from an official broadcast by TRC Healthcare.
Specifically, it's a panel of clinical experts on their program called Medication Talk.
Exactly. And our mission today is to cut through all that overwhelming, conflicting noise surrounding menopause symptom management. We're looking at the hard evidence behind hormone therapies, unpacking the actual mechanisms of how they work, and debunking some massive marketing myths along the way.
And we're also going to explore some truly unexpected non-hormonal fixes, which I think will surprise a lot of people.
Totally. So the goal is to give you, the listener, absolute clarity. If you are prepping to negotiate with your doctor or just catching up on the literature, or honestly, if you're just curious about how human physiology adapts to this massive endocrine shift, understanding these mechanisms changes everything.
It really does. It's not just about giving you a list of drugs. It's about understanding the why and the how.
Right. So let's start with the frontline defense, menopausal hormone therapy, or MHT.
Right.
The delivery route, like how the hormone actually gets into your body, changes its entire safety profile.
Yes, the delivery route is crucial.
Because we know that for vasomotor symptoms, those intense hot flashes and night sweats, we need systemic delivery.
Right, the hormone needs to be in your bloodstream.
But for genitourinary symptoms, local delivery is enough. But looking at the systemic options, the panel notes that transdermal patches minimize the risk of venous thromboembolism.
So blood clots.
Right, blood clots. The patches minimize that compared to oral pills. So my first question looking at this was, if a patch avoids the liver and drops the blood clot risk, why is an oral pill even still on the market?
Well, it comes down to first-pass metabolism. When you swallow an estrogen pill, it goes straight to your liver.
Okay.
And the liver processes it, but in doing so, it inadvertently ramps up the production of clotting factors.
Oh, wow.
Yeah. But a transdermal patch bypasses the liver entirely. It absorbs directly into the bloodstream through the skin, which keeps that clot risk right at baseline.
So no extra clotting factors are produced?
Exactly. But to answer your question about why we still use pills, biology is just highly individualized. I mean, some patients have severe dermatological reactions to the adhesives in the patches.
Oh, like terrible rashes and stuff.
Right. For others, the out-of-pocket cost of patches is just prohibitive compared to a really cheap generic pill.
That makes sense.
And surprisingly, oral estrogen can sometimes have a more favorable impact on a patient's lipid profile.
Wait, really?
Yeah, it can specifically lower LDL cholesterol precisely because of that liver processing we just talked about.
Oh, because the liver is the cholesterol factory.
Exactly. So if a patient has no history of blood clots, no compounding risk factors, an oral pill remains a highly viable, very useful tool.
So it's basically a trade-off. You bypass the liver to save the veins, or you use the liver to hit the cholesterol, depending on what the specific patient needs.
That's a great way to summarize it.
Okay, so if we add the other major variable to this equation, we get the progesterone puzzle.
Yes, the brakes.
Right. The clinical consensus here is absolute. If a patient still has a uterus, they must take a progesterone alongside their systemic estrogen.
Always.
And to visualize this, listener, think of it like the mechanisms of a car. Estrogen is stepping on the gas pedal for cell growth in the uterine lining, the endometrium.
And progesterone acts as the brakes.
Right.
And without those brakes, that continuous endometrial proliferation, it just leads straight to hyperplasia and potentially uterine cancer.
Which is obviously what we're trying to avoid.
Exactly. Progesterone provides an endometrial shield, but we have to clarify that progesterone is just an umbrella term.
Right. The panel broke this down into two main types.
Yes. Under that umbrella, we have micronized progesterone and we have synthetic progestins. And they behave very differently in the body.
So let's start with the micronized one.
Okay, so micronized progesterone is structurally identical to the hormone naturally produced by the ovaries. And because of its specific molecular shape, when it breaks down, its metabolites actually bind to GABA receptors in the brain.
And GABA is the neurotransmitter that calms the nervous system down.
Precisely. Which is why micronized progesterone has this really nice, mild sedative effect.
Oh, so you take it at night.
Exactly.
Yeah.
Patients take it at bedtime, and it actively helps with menopausal insomnia.
Which is huge. But there is a significant hurdle here that the panel flagged, which I thought was wild. Standard micronized progesterone is formulated in peanut oil.
Yes.
So, listener, if you have a peanut allergy, that quote-unquote natural option is entirely off the table for you.
It's a very real constraint, which naturally brings us to the synthetic progestins.
Right. How do those work?
So synthetic progestins, like the ones you'd find in standard birth control pills, they are engineered to bind very tightly to progesterone receptors.
Okay.
They are incredibly potent right at the level of the uterus. So let's say a patient is in perimenopause and they're struggling with heavy, chaotic, abnormal uterine bleeding.
Which happens a lot.
Very frequently. Hitting the brakes with a highly potent synthetic progestin is far more effective for controlling that bleeding than the micronized version would be.
Because it's just stronger locally.
Right. Providers will often use a synthetic levonorgestrel IUD to lock down the uterus locally while putting an estrogen patch on the patient's skin to handle the systemic hot flashes.
That is such an elegant solution. But hold on, I'm looking at this data on the word micronized, meaning structurally identical to ovarian hormones, and I'm a bit confused. Because this brings us right into bioidentical hormones, which is easily the most hijacked buzzword in wellness right now.
Oh, absolutely. It's a marketing minefield.
Right. So if my standard pharmacy patch has the exact same chemical structure as the custom cream from some compounding pharmacy, why is the medical community screaming at us to avoid the compounded stuff? Like, isn't it all the same?
Well, chemically, the active hormone might be the same, but the delivery and the manufacturing are just worlds apart. Well, bioidentical just means the molecule matches human estrogen or progesterone. That's it. FDA-approved products like the estradiol patches at your local pharmacy, those are bioidentical.
Right.
But they are manufactured under strict regulatory oversight. We have vast pharmacokinetic data on them.
Meaning we know exactly what they do in the body.
Exactly. We know exactly how much hormone enters your bloodstream at what rate over what period of time. But when you go to a compounding pharmacy for custom mixed hormones, you lose all of that data.
Because it's essentially a boutique recipe mixed in the back room.
Yes. I mean, a 2020 deep dive by the National Academies of Sciences, Engineering, and Medicine found a complete dearth of evidence that compounded hormones are safer or more effective.
A complete dearth.
Literally none.
Yeah.
You don't know the absorption rate of that specific cream base they used. You don't know if the hormone is evenly distributed in the batch.
So one pump could be nothing, and the next pump could be a massive dose.
Exactly. The clinical community warns against it because you're taking a massive gamble with your endocrine system.
So is there ever a reason to use a compounding pharmacy?
The panel noted the only legitimate use for compounding in this context is an allergy constraint.
Oh, the peanut allergy.
Right. If you need that micronized progesterone for your sleep, but you have the peanut allergy, a compounder can safely suspend that exact FDA-approved hormone into olive oil for you instead.
Okay, that makes the distinction incredibly clear. But the most alarming trend in this unregulated space seems to be hormone pellets.
Oh, the pellets.
Yeah, clinics are inserting these estradiol or testosterone pellets under the skin, and the endocrine societies are actively telling patients to run the other way. Why are they so bad?
Well, the pharmacokinetic problem with pellets is that they create superphysiologic hormone levels.
Meaning way more than normal.
Right. They flood the body with amounts of estrogen or testosterone it would never, ever naturally produce. But honestly, the greater danger is the complete lack of titratability.
Once it's in, you can't get it out.
You are totally stuck. If a patient develops severe side effects like aggressive acne, severe mood destabilization, abnormal bleeding, the provider cannot just lower the dose.
You just have to wait it out.
You have to wait months for the pellet to dissolve on its own. And furthermore, your cellular receptors can become desensitized to those massive hormone floods.
Oh, wow.
It's a process called tachyphylaxis, which basically means you eventually need higher and higher doses just to feel normal.
That sounds like a physiological trap.
It really is.
Okay, so assuming a patient avoids all that and gets on a highly regulated, FDA-approved therapy, the timeline becomes the next major variable.
Right, the when and the how long.
Exactly. The panel states therapy should ideally start within the first 10 years of menopause, but what happens when they want to stop? We see this debate between stopping cold turkey versus tapering.
Yes, a very common question.
And I want to get the mechanism right here, so let me run this analogy by you.
Okay, go for it.
Entering menopause kind of feels like taking a steep, high-speed roller coaster drop. The hot flashes and the misery are the stomach-dropping free fall.
Right.
Hormone therapy essentially slows the ride down to a gentle, manageable ramp. When you finally taper off the therapy years later, you aren't plummeting anymore, you're just stepping off the ride at the station.
I love that. That is a much more accurate way to look at it, because there is no life-threatening physiological event triggered by abruptly ripping off an estrogen patch.
You're not going to have a stroke from stopping.
No, you aren't going to induce a stroke. But your vasomotor symptoms will almost certainly rebound violently.
So the hot flashes come roaring back.
Yes. So tapering is purely a strategy for symptom mitigation.
Yeah.
It allows the hypothalamus, which is your brain's thermostat, to gently recalibrate to the new, lower baseline of estrogen over months rather than hours.
And understanding that really empowers patients, I think, to see MHT not as life sentence, but just as a transitional tool.
Exactly. You're not trapped on it.
Now, that mechanism with the brain's thermostat opens up a completely different problem for patients who can't take hormones at all.
The non-hormonal candidates.
Yeah. Listener, if you have a history of estrogen receptor-positive breast cancer, you can't use that hormone ramp. But the panel provided some really surprising level 1 evidence for non-hormonal medication.
Yes, they did.
Specifically SSRIs and SNRIs, which are traditionally antidepressants.
Right.
So why doesn't antidepressants stop a hot flash? I always thought hot flashes were just a lack of estrogen.
Well, they are, but the lack of estrogen is the trigger, not the actual mechanism.
Oh, interesting.
Yeah. So the hypothalamus controls your body temperature, and it relies heavily on serotonin and norepinephrine to maintain a normal thermoneutral zone.
Thermoneutral zone being the temperature range where you feel comfortable.
Right. Now, when estrogen levels plummet, those neurotransmitters get totally dysregulated, and that thermoneutral zone narrows dramatically.
So your buffer is gone.
Exactly. Suddenly, a tiny microscopic shift in core body temperature makes the brain think you are overheating, and that triggers a massive, inappropriate cooling response, which is the hot flash.
So the SSRIs, medications like paroxetine, citalopram, they step in and fix the thermostat.
Exactly. By increasing the availability of serotonin in the brain, they artificially widen that thermoneutral zone back out.
So the brain stops triggering those false overheating alarms.
You got it. And SNRIs like venlafaxine do the exact same thing, just with norepinephrine.
But there is a massive drug interaction warning here that we need to talk about. The panel explicitly stated that paroxetine should never be given to a breast cancer patient taking tamoxifen.
Never.
But if paroxetine is level 1 evidence for hot flashes, why block the exact group who needs it most?
It comes down to a specific liver enzyme called CYP2D6.
Okay.
Tamoxifen is actually what we call a prodrug. It doesn't fight the cancer on its own.
Oh, I didn't know that.
Yeah, it has to be processed by that CYP2D6 enzyme to convert into its active cancer-fighting form, which is called endoxifen.
Okay, so it needs the enzyme to work.
Right. But paroxetine is a potent inhibitor of that exact enzyme. So if you take them together, the paroxetine blocks the enzyme, the tamoxifen never converts, and the patient's cancer recurrence risk just shoots up.
That is terrifying, but so vital to know.
And beyond the cancer risk, paroxetine is notorious for causing weight gain.
Which nobody wants during menopause.
Right, women are already battling metabolic slowdowns. Adding a drug that accelerates weight gain is totally counterproductive.
So what's the alternative?
Providers will usually pivot to a different SSRI, like escitalopram.
Right.
It has less weight impact, and crucially, it doesn't inhibit that CYP enzyme.
Got it. Now, the non-hormonal toolbox also includes gabapentin. The panel noted it's a GABA analog, so it causes drowsiness, which is a massive win for menopausal insomnia.
It is, yeah.
But to actually suppress the hot flashes, you have to push the dose so high that the central nervous system side effects become debilitating for a lot of people.
Right, the dizziness and fatigue can be too much.
And there's also oxybutynin, which relies on an anticholinergic mechanism. It essentially blocks the chemical messenger that triggers sweat glands and bladder contractions.
Yes.
So if a patient has hot flashes and an overactive bladder, oxybutynin knocks out both.
It's a great 2-for-1 option.
Yeah. But what about the new class of drugs? The neurokinin receptor antagonists like fezolinetant and that newly approved 2025 drug, Alinzinatant.
Oh, these are fascinating from a biochemical perspective. They target a specific group of neurons in the hypothalamus called KNDY neurons.
KNDY.
Right. Estrogen usually keeps these neurons quiet.
Right.
But without estrogen, they hypertrophy and they fire wildly, which is just another part of that hot flash mechanism.
Okay.
So these new drugs directly block the neurokinin receptors to silence those firing neurons.
It's very targeted, but honestly, the clinical panel was pretty lukewarm on them. Why is that?
Well, it is the gap between clinical trial data and real-world application.
The classic problem.
Exactly. In the trials, they reduced vasomotor episodes by about 60% versus 40% for the placebo.
Which is statistically significant.
It is. But in the clinic, patients are facing astronomical out-of-pocket costs, fierce insurance denials, and when they finally take the pill, the subjective relief often just doesn't match the immense effort and financial burden it took to get it.
It's just not a miracle cure for most.
No, it isn't.
You know, looking at all these medications, the lifestyle intervention data totally subverted my expectations. I saw cognitive behavioral therapy, CBT, and clinical hypnosis on the list, and I admit I assumed they were just nice placebo-adjacent ways to relax.
A lot of people assume that.
Right. But the panel rated clinical hypnosis as a level 1 intervention. How does hypnosis rival a drug-altering KNDI neurons?
Because it alters the nervous system's reactivity. Hypnosis and CBT aren't just deep breathing exercises.
Okay.
A trained professional is actually teaching the brain to downregulate the sympathetic nervous system, the fight-or-flight response.
Oh, wow.
Remember how we said hot flashes are a false alarm?
Right, the brain panics over a tiny temperature shift.
Exactly. Well, hypnosis changes how the brain perceives that thermal trigger. It activates the parasympathetic nervous system so that even when the hypothalamus detects a temperature shift, the systemic physiological panic is just muted.
So you still get the shift, but your body doesn't freak out.
Right. It is neuroplasticity in action, and it's heavily supported by clinical trial data.
That mechanism really underscores how systemic menopause is. It's not just a reproductive event, it is a neurological one.
Absolutely.
Which perfectly brings us to the final piece of the puzzle, the complex trifecta of weight, libido, and brain fog.
A big three.
The big three. Let's start with weight. We know menopause shifts fat distribution from subcutaneous to visceral, so belly fat.
Right.
And a 2024 study looked at combining GLP-1 receptor agonists like semaglutide with menopausal hormone therapy.
The synergy here is really compelling. Patients on both therapies achieved greater weight loss than those on GLP-1s alone.
Well, that's interesting because of the hormones.
Yes. MHT helps mitigate the metabolic slowdown and shifts the fat distribution back to a healthier profile, while the GLP-1 handles the satiety and caloric intake.
That's a two-pronged attack.
It is. But the panel emphasized a really critical caveat here, which is sarcopenia.
Muscle loss.
Yes. GLP-1s cause indiscriminate weight loss, meaning fat and muscle.
Yeah.
And as estrogen drops, maintaining muscle mass already becomes incredibly difficult.
So you're losing muscle from both sides.
Exactly. If a patient is using this combined therapy, heavy strength training is absolutely non-negotiable to protect their skeletal muscle and their bone density.
Okay, moving to genitourinary syndrome. We talked about local estrogen earlier, but the panel outlines some other distinct mechanisms. There are long-lasting moisturizers like Replins,
Right.
but on the prescription side, there is ospemifene. It's a SERM, a selective estrogen receptor modulator. Let me make sure I understand this. It acts like an estrogen in the vaginal tissue to thicken and heal it, but it blocks estrogen receptors in the breast tissue to keep it safe.
That is the exact mechanism of a SERM. It is tissue-specific.
That is so cool.
It really is. It provides oral relief for painful intercourse without stimulating breast tissue. However, because it acts as an estrogen agonist in the blood vessels, it does carry a blood clot risk, similar to oral estrogen.
Got it, so it's not risk-free. And then there is Progesterone, which relies on a totally different pathway. It's a daily vaginal insert of DHEA.
Yes, and this is a brilliant use of localized biochemistry. DHEA is basically an inactive precursor.
Okay.
When you insert progesterone, the specific cells lining the vagina absorb it. And inside the cell, an enzyme called aromatase converts that DHEA directly into estrogen and testosterone.
So the conversion happens right where you need it.
Exactly. The healing happens entirely intracellularly. Because it never enters the bloodstream, it doesn't raise systemic hormone levels, making it an incredibly safe option.
And the fact that it converts to testosterone locally leads right into the libido discussion.
Yes, it does.
Because the clinical consensus was stark. There is only one evidence-based reason to prescribe testosterone to a female patient in menopause, and that is hypoactive sexual desire disorder.
Low libido.
Right.
And specifically, it must be topical testosterone. We have androgen receptors in the brain that directly modulate sexual desire.
Okay.
When testosterone drops, those receptors aren't stimulated. Properly dosed topical testosterone effectively targets those receptors.
What about the non-hormonal pill for libido, Eddie?
Flavanserin. It targets serotonin and dopamine pathways in the brain. But honestly, real-world data shows it is largely ineffective for the vast majority of menopausal patients.
And it has some pretty bad side effects, right?
Yes, it comes with strict warnings about alcohol interaction and severe hypotension. Topical testosterone remains the absolute gold standard here.
Good to know. Okay, finally, we arrive at the symptom that causes the most sheer panic for people: brain fog.
Oh.
Women report forgetting words, losing their keys, feeling like their cognitive sharpness has just evaporated. And I have spoken to dozens of women who swear that starting hormone therapy cleared their heads completely.
Right.
But the panel stated very clearly that hormone therapy is neutral on brain fog. It does not directly improve cognition. So if it's neutral, why does it work for so many people?
It is a profound demonstration of a causal chain. Hormone therapy does not cross the blood-brain barrier to repair cognitive circuits.
Okay.
What it does is treat the vasomotor symptoms. Think about it. If a patient is having 8 intense night sweats every single night, their sleep architecture is being decimated.
They're waking up constantly.
Exactly. They're never reaching deep, slow-wave sleep.
And deep sleep is when the brain literally washes itself of metabolic waste.
Exactly right. Severe chronic sleep deprivation physically manifests as brain fog, memory loss, and cognitive decline. By using hormone therapy to eliminate the night sweats, you restore the patient's sleep architecture. It is the restorative sleep that clears the amyloid proteins and cures the brain fog.
So the hormones just paved the way.
Precisely.
The hormones fix the sleep, and the sleep fixes the brain.
You got it.
Which basically brings us back to where we started. For 2 decades, the FDA maintained a black box warning on hormone therapy, warning patients it could cause dementia.
Yes. Based on early, deeply flawed interpretations of the Women's Health Initiative study.
Which looked at women starting hormones in their late 60s and 70s, long past that initial 10-year window we talked about.
Exactly. The data was misapplied.
And now that warning is gone. The FDA quietly removed it because the data simply did not support it. We have spent 20 years terrifying patients away from a therapy that could have restored their sleep and protected their quality of life.
The removal of that black box is a monumental course correction. It lifts a cloud of medical anxiety that never should have been there in the first place. It allows patients to evaluate MHT based on actual individualized risks, not phantom terrors.
Listener, if you take anything away from this deep dive, it's that the era of white-knuckling through the endocrine shift of menopause is over.
Thankfully.
Whether you need a systemic patch, a strictly local SERM, an SSRI that navigates safely around your cancer medication, or even a referral for clinical hypnosis, you have a highly customizable, evidence-based toolkit at your disposal.
And I'd leave you with this final thought. Millions of women suffer through severe symptoms because a regulatory agency slapped a dementia warning on their most effective treatment option. A warning we now know was structurally and scientifically unfounded.
Right.
So if the medical establishment is just now catching up to debunking a decades-long error of that magnitude, what other deeply ingrained clinical assumptions about women's bodies, pain, and aging are we accepting as absolute truth today that will be proven completely wrong tomorrow?
Keep questioning the baseline, demand the mechanisms, and always demand the data. Until next time.